Hello and welcome to Everyday Medicine. I'm Dr. Luke and I'd like to thank you for joining me on this podcast series where we share conversations with colleagues, exploring their special interests in medicine and bringing insights, ideas and advice which I hope will be applicable for our medical practices. In this episode, we're talking with an expert about common problems in ophthalmology. And for Australian audiences, listening does give you eligibility for your CPD, so log in and add this as an activity. You may also consider journaling, reflection, and adding to the review and performance section in your CPD. Well, in the evolution of sight, primitive single-celled organisms only had patches of photoreceptor proteins that could detect light. The first eyes probably developed over 550 million years ago and are now considered to be the second most complex organ after the brain, with over 2 million working parts and more than 1 million nerve fibres connecting each eye to the brain via the optic nerves. The eye has been the subject of fascination and conflicting interpretation since antiquity, with Plato stating that light emanated from the eyes, seeing objects with its rays. His idea was also supported by Galen, and the eye received further special interest from medieval Islamic physicians, yet it took Kepler in 1604 to offer the first theory of the retinal image. Of course, apart from their unique function in allowing us to explore and discover the world in which we live, the eyes give us personality and romantically provide a window to our souls. To briefly review the anatomy, the eye is protected by the eyelids and is comprised anteriorly by the conjunctiva, deep to which is the cornea, contiguous with the sclera laterally. Deep to the cornea is the anterior chamber filled with the aqueous humor, a thin, transparent fluid similar in composition to plasma that both nourishes the cornea and lens, but also gives the eye shape. The iris controls pupil size. Light is focused through a lens and then the posterior chamber, which also contains vitreous humor, before falling on the retina. And the retina is the specialized part at the back of the eye which contains 3 types of cells that convert light energy to electrical energy used by the nervous system. And these cells include rods, which respond to low-intensity light and contribute to perception of low-resolution black and white images, cones, which respond to high-intensity light and contribute to perception of high-resolution colored images, and ganglion cells, which respond to full range of light intensities, contribute to adjusting the amount of light reaching the retina, and regulate the hormone melatonin, which influences circadian rhythm. Unfortunately, this amazing organ is commonly subject to pathology affecting its unique function, and it's estimated that over 13 million Australians have one or more chronic eye conditions, and that chronic eye disorders affect as many as 93% of people aged 65 years and over, females experiencing a higher prevalence than males. Such conditions include refractory disorders such as hyperopia, myopia, presbyopia, astigmatism, as well as colour blindness. A recent survey, about 550,000 Australians were noted to have colour blindness. Cataract, macular degeneration, and blindness, which affects about 131 Australians, are also notable conditions, of course, as diabetic retinopathy, strabismus, amblyopia, venous occlusions, retinal detachment, disorders of the lid and lacrimal apparatus, conjunctivitis, pterygiums, pinguicular, optic neuritis, the list goes on, oculomotor, cranial nerve palsies, as well as ocular injuries, all broadening the depth and complexity of ophthalmological practice. I think some conditions do warrant further mention. These include age-related macular degeneration, which is the most common cause of irreversible vision loss. It affects 1 in 7 Australians over the age of 50. It's a heterogeneous condition with both genetic and environmental risk factors and a poorly defined pathogenesis. Well, the macula is the part of the eye responsible for central vision, and it's found in the retina, 3 millimeters lateral to the optic disc. It measures just 5 millimeters in diameter, yet provides most of the daytime vision. And tasks such as reading, recognizing faces, and driving rely on macular function and are significantly impaired in advanced macular degeneration. Cataracts are lens opacities that significantly impact quality of vision over all distances and are a leading cause of visual impairment, and several factors including systemic diseases such as diabetes, medications such as amiodarone and trauma can lead to lens opacities. However, age-related cataracts are the most common and are divided into nuclear, cortical and subcapsular types. And cataract surgery is the most common elective procedure performed in Australian public hospitals, averaging 8.6 per 1,000 people. Thirdly, glaucoma is the world's leading cause of blindness and is largely asymptomatic in its early stages. It affects about 300,000 Australians, up to 3% of our population, with about 1 in 10 developing glaucoma by the age of 80. It's a group of conditions that leads to a characteristic pattern of damage to the optic nerve with a corresponding visual field defect and is often associated with increased intraocular pressure, although normal tension, open angle glaucoma is noted in between 20 to 30% of Caucasian cases. The prevalence rate of glaucoma increases significantly over the age of 50 years and is classified according to the structure of the anterior chamber iridocorneal angle into either open angle or angle closure, indicating different mechanisms of aqueous flow obstruction. On this episode, we have a conversation with Dr. Rogan Fraser, who's completing his fellowship in ophthalmology and will introduce us to common problems in this field of medicine, including an approach to managing red eye, the importance of ophthalmic complications such as shingles, giant cell arteritis, ophthalmic side effects of semaglutide, which is Ozempic, as well as the clinical problems of glaucoma, retinal vein occlusion, and macular degeneration. This certainly is a quick focus tour of some very important topics in ophthalmology from a young and impressive specialist who I'm predicting will have a significant positive influence on this area of medicine for decades to come. So please welcome Dr. Rogan Fraser to the podcast. Rogan Fraser, thank you very much for coming to Everyday Medicine. It's a real honour to have you here, and I know you're flat out there in the ophthalmological world, practicing the dark arts of ophthalmology, Rogan, that I know very little about.
I think flat out and ophthalmology is an oxymoron, but I'd take it as a compliment.
Well, it's very, very nice for you to join me, Rogan, and we're going to discuss ophthalmological conditions that we should know in primary practice. And, I think for a lot of us who have gone through medicine, we probably haven't had maybe the exposure to understanding ophthalmological problems that we would have liked. So it's a real honour to have you here, and I'm really looking forward to the conversation. Can you give me, though, before we start on that, a little bit of a background, your journey, Rogan? How did you get here?
I think you know a little bit about my journey, and I would say it's more circuitous than most of my generation, but I think increasingly people are coming to medicine in different ways, and I was one of those people. I'd say it started as being a bad high school student. I had a few too many beers before my Year 12 maths exam and didn't get good marks in high school, but in any case, didn't have aspirations to do medicine. I wanted to be a journalist. So I thought I'd be a sports journalist. Sort of my own revisionist history, think of myself as a wannabe political journalist, but both of those fell by the wayside. I then came to Melbourne. So I was in Brisbane for journalism, came to Melbourne and did science with a view to getting into optometry, and eventually did that. As you know, practiced optometry in a small regional town in West Gippsland for a few years, and probably about 6 months in realised that I wanted to do a little bit more for my patients, and was also a fraction intellectually frustrated. And so went back to do medicine, really with a laser focus, bad pun, on ophthalmology. And I was lucky enough to spend only about 3 years doing sort of general hospital medicine, and then moved into ophthalmology. I should say I've listened to a few of your other podcasts, and I think I am much less esteemed than many of your previous guests. I'm still technically a trainee, albeit an advanced trainee, but post-exams, if that counts for something, which it does in my world.
Well, it certainly does. And I think I'm just really so proud to hear about your story too, Rogan, because you've just pushed and tried, and it's been a long journey. Sometimes these journeys just seem to be so hard to get into. The training just seems to be so difficult to get a club.
Yeah, I mean, I think we're starting to see unaccredited ENT registrars apply for ophthalmology. So I suspect the pendulum has swung in a different direction, whereby maybe some of these surgical specialties are even more difficult now. But yeah, look, it's challenging, like it is for lots of these subspecialty training programs, to get on in the first place.
Yeah, but it is a privilege to be on a training program and to be able to learn in depth about a subject. I agree with you. It's incredibly rewarding.
Absolutely.
And then, as you say, you can offer a different type of assistance to your patients that maybe most of us couldn't in other fields. But I wanted to ask you a little bit about these sort of ophthalmological problems. You're seeing a lot that come through the referral system to the eye and ear there. Tell us a little bit about maybe, say, red eye. Can we start with that one? Would that be okay? Yeah. Tell us what you need to know. What are the essentials? What do we have to look for? Tell us how we become good pupils.
Yes. We're trading puns. Very good. I think red eye, obviously, statistics I've read make up somewhere between 10 and 20% of all presentations to general practice. And it obviously is a vast spectrum of disease. And I think the classic teaching, and maybe even this extends back to certainly as far as my parents-in-law, is the, beware the unilateral red eye. And I think it's a dictum that is actually fairly should be heeded. So I think the genesis of that is your benign conditions are less likely to be unilateral. So your conjunctivitis, for example, a little detour with conjunctivitis. So more than 95% of conjunctivitis, adult conjunctivitis that present in general practice are going to be viral conjunctivitis, and about 95% of those will be adenovirus. And that's a long way of saying the treatment is effectively mindful monitoring. So we see a lot of patients on Chlorsic, and that's a completely harmless intervention, but also useless. So I think sometimes it's hard in medicine to just tell a patient that you will get better and provide reassurance. But what I sometimes find with these patients that are on Chlorsic is there's an expectation that they should have got better. And so we see perhaps unnecessary presentations to us. But in general, thinking about the unilateral red eye.
Rogan, can I ask you there just very briefly? So that very small group that may be bacterial, is there any way of picking that? Or is it only by taking a culture? Can you tell, that's likely to be bacterial, the 5% that isn't viral?
Yeah. There are clues, I think, other than taking a culture or checking for a viral PCR. It's difficult to know definitively. But for example, the discharge in a bacterial conjunctivitis is more like purulent or on the way to purulent, like a mucopurulent discharge.
Right. Yeah.
It actually is more likely to stay unilateral if someone has fastidious hand hygiene, which increasingly we all do, or are at least better at. It's far more common in children, though less common than it was before we started vaccinating for Haemophilus influenza. And then if you look, this is subtle, but if you look in the eyelids, so the lower part in particular of the eyelids, you can see these sort of bulbous collections, which we call papillae, and they look more like sort of mini volcanoes, whereas in a viral one, you may have these little rice grains in the lower eyelids. So that would make me think rice grains, viral, little volcanoes, bacterial, and then often preauricular lymph nodes make you think of a viral infection as well.
Yeah, that's a very good point. Great pointers. Okay. So coming back to the red eye, that's the conjunctivitis, which is more...
I think the other thing to ask is just you basically just looking at your symptoms. So a conjunctivitis will generally be an irritated, bilaterally irritated eye. Patients aren't in dreadful pain. They shouldn't really be describing photophobia. So those are all warning signs. So I think if you red flags that I think of with the red eye is any change in vision, any photophobia, the unilaterality of it, and then to some extent the chronicity of it. So if ever you have a red eye that's neither not responding to treatment or carrying on for a long time, in the absence of treatment, you'd be thinking of either other infectious etiologies or indeed an inflammatory or autoimmune etiology.
Okay. And with those sort of thoughts, is that that's really a time where you might be in primary practice saying, okay, I'm going to refer this case off now. I need some assistance, and often come to the ophthalmological consultant.
And I think part of it is that to successfully diagnose these problems, you need the right equipment, and I don't know of many GP practices that have a slit lamp. So, certainly in regional Victoria, as an optometrist, I would see a lot of these patients, and I think this is my little plug that optometry they're fantastic. I think of them as the GPs of the eyes, though those careful listeners will appreciate that there's some selection bias in that comment. Look, I think any of those red flags, it's time to either seek the help of a local optometrist or in some cases ophthalmology.
Okay, I'll move them on. Okay, so that's red eye. Anything else we should be thinking about red eye, or should we move on to the next subject?
Look, we often one of my consultants told me once that whenever you get a call about angle closure glaucoma, it's never actually angle closure glaucoma. And I think we, very importantly, as general doctors, remember the horrific stories about angle closure glaucoma. So maybe just to reiterate what that is and how that presents, it's going to be an older person. They tend to have a unilateral red eye. They often have it after, say, they've come out of the movie theatre or a car park because they've been in the dark, their pupils dilated, and it comes down and it gets stuck in this mid-dilated position. The symptoms they describe are nausea, vomiting, pain around the eyes, and when they look at lights, they see halos. Now that's an ophthalmic emergency, or as close to an emergency as we get. So that's certainly not a trip to the optometrist, but a trip straight to the nearest. In Melbourne, luckily, the eye and ear emergency department, but there are other places or local ophthalmologists that you can lean on for that kind of thing as well.
Do you see that sort of emergency sometimes in the setting of use of anticholinergic drugs, antispasmodic drugs?
Yeah, I've seen
something you've seen, ditropan or buscopan, or
I've never seen it with ditropan. I've seen it with topiramate. So it's described. So people get ciliary body effusions in topiramate, and they get like a type of angle closure syndrome.
Right.
The treatment is a little different. Medication cessation is sort of the cornerstone, and we can generally manage it without any particularly invasive intervention like laser. But yeah, it's well described that those medications can cause it.
And just to inform me, so if you did have an emergency like that, which was the angle closure glaucoma, what is your treatment of that? What is the acute treatment? Yes, if it's different, like we've mentioned, but what are the other ways in which you manage that?
So often if I get a call, a very convincing call from another emergency department, I'll tell them to start a battery of drops and acetazolamide. We give acetazolamide. Rarely we give mannitol, and we give terrifying doses of mannitol as far as the anaesthetists are concerned, up to 2 grams per kilogram, which is significantly more than what they give for intracranial hypertension. So I appreciate that it's terrifying. And then definitive treatment is shifting a little bit, but in the emergency department, we put a laser hole through their iris just to break the cycle and enable the aqueous to travel,
yes,
from the anterior to the posterior chamber through a new hole. But increasingly, there's some studies that were done which showed that maybe just taking out the cataract, so the lens behind the iris, which has caused the problem in the first place, has blocked up the space, may be in fact preferable, both from a health economic and health quality of life perspective.
Perfect. Okay, well, that's red eye. It's just like all these subjects, you can dive in and talk about these sorts of things for hours, but we'll move on to the next one, which you raised this concern with me about shingles. Tell us a bit about shingles. What should we know about that in primary practice?
Yeah, so I think I'll be preaching to the converted here when I say that the shingles is an increasingly prevalent problem, and my understanding is we don't really know why. I remember when I first started at the eye and ear hospital, I would frequently see 25, 30-year-olds with shingles, and I thought, this can't be right, and spoke to a very eminent infectious disease physician at St Vincent's who just sort of laughed it off and said, no, this is reality now. These people get shingles, not as much, but they get shingles, and it's not because they're immune suppressed, it's because that's what happens. So it's very prevalent, and 20% of all shingles in some studies is herpes zoster ophthalmicus. And the point I'd like to make about herpes zoster ophthalmicus is the treatment is a little different, and it's a little different in a few ways. Even if it's beyond the 72 hours, we would always treat with an antiviral because the potential consequences are profound. The antiviral dosing is a little different. So it's the same as for Ramsay-Hunt, but that's twice what it is for shingles, cutaneous shingles in any other dermatome. That's my understanding. And unfortunately, PBS, I think, haven't helped in this regard because PBS fund famciclovir, but only for 250 milligrams of TDS, whereas the herpes zoster ophthalmicus dose to treat for famciclovir is double that, so 500 milligrams TDS. So we often see patients coming to us with an undertreated herpes zoster ophthalmicus. And in one, dreadful case, which could have happened anyway, there was a patient who developed herpes zoster meningitis and herpes zoster optic neuritis and went blind from that. So just worth remembering that if you're using valacyclovir or acyclovir or famciclovir, it's twice the dose. So that's 800 for acyclovir, 1 gram for valacyclovir, and 500 for famciclovir. The other thing I would say, and I really lean on the GPs for this, both information and delivery of care, is that there's real value in these, especially the newer the shingles vaccines, the Shingrix in particular. So specifically for shingles, I think a greater than 90% reduction in recurrence if it's given after the resolution of an acute episode of shingles. And that's the same for herpes zoster ophthalmicus. So it seems to be a fantastic vaccination. It's a shame it's expensive. But I think if we can convince our patients to get it, I mean, I'm thinking about getting it myself because these patients, and you may have seen them too, the post-herpetic neuralgia is just absolutely dreadful. Yeah.
I actually had my first Shingrix today.
Oh, fantastic. Look at that. We did not plan this. I can tell everyone.
And what you've described is the motivating factor for me. And also there's been a little review of the Shingrix in Nature. I don't know whether you've seen this, like 300,000 people in Wales, and there's a reduction in dementia. I haven't seen the exact method in which they've come to this conclusion, but a 20% reduction in the incidence of dementia.
Right.
So, which is an interesting slant on why some people perhaps get dementia. But my arm is actually a little bit sore today. I get vaccinated against everything I possibly can.
Yeah.
And it's a little bit sore. It's a bit sore, but I have to have another one in 2 to 3 months' time, and it is expensive. It was about $340, so that's a great shame. And for all the patients now that are on immunosuppressant therapy, and there's a lot of patients on various biologic therapies, unfortunately, that they're not supported at this stage by our PBS, which is a great shame. So we have to self-fund. But I'm with you. I'm a huge fan of the vaccination.
Yeah.
So thank you for that. Another curly one, giant cell arteritis. Tell us a little bit about that.
Yeah. So I spoke briefly about, acute angle closure glaucoma being an ophthalmic emergency. I think really our ophthalmic emergencies are giant cell arteritis and a retrobulbar hemorrhage or an orbital compartment syndrome. And I think it's easy to forget that giant cell arteritis is an emergency for us. And I think every ophthalmologist has at least one horror story about something they wish they'd done differently when they had a patient that might have had giant cell arteritis. So I just wanted to talk a little bit about when to think about giant cell arteritis, the questions to ask, and when to involve ophthalmology, and maybe even just briefly about how we treat giant cell arteritis. So first thing, and again, I think I may be telling people what they already know, so sorry if that is the case, but it's a disease of old age, so certainly described in patients over 50, but far more common in patients over 60, and then 75 is really the big category. Women more than men, somewhere in the vicinity of 2 to 6 times. Caucasians, ethnic Caucasians, again, a preponderance of those in the patients diagnosed with giant cell arteritis, but certainly described in most ethnicities. And then symptoms, questions that I ask, and this is based on, so there's a very eminent Indian ophthalmologist who recently passed away called Sohan Hayray, who wrote extensively about giant cell arteritis and had it himself, actually. And he looked at and he's not the only one, but he looked at what are the most specific or symptoms that have the most positive predictive value. And certainly jaw claudication in most study comes up far and away as the most likely symptom for patients to be associated, or has the highest specificity when we're thinking about symptoms associated with giant cell arteritis. And a local Sydney neuro-ophthalmologist, Claire Fraser, actually developed a test called the chewing gum test, which was published in the New England Journal of Medicine, where I think she got a consecutive series of 20 patients to chewing gum for 20 minutes, and the concordance with positive temporal artery biopsy was like nearly 100%. It was remarkable.
Okay, I don't know. That's interesting.
So maybe just keeping a little set of extra.
She's got a lifelong supply from Wrigley's, has she?
That's right, yeah. So financial disclosure, I didn't read the bottom of that article. Jaw claudication, and then headache we get a lot of patients with headaches. Is this GCA? And self-headaches are almost ubiquitous, and so it's not a very good discriminating symptom, but I think is still always worth thinking about in an elderly person with headaches, and maybe one other of those constitutional symptoms of GCA, things like neck pain, PMR type symptoms, yes, loss of weight, loss of appetite. Then, of course, we look at inflammatory markers, and it's the age-adjusted ESR, which we use, generally speaking, as being more likely to be predictive of presence of temporal arteritis or GCA. So I think the rheumatological diagnosis or classification describes ESR over 50, and that is pretty much what we would think of with the age-adjusted norms in this age group. The reason we think of GCA as an ophthalmic emergency, and I'll just give you one horror story that my friend told me, is he was a registrar in Geelong, and he got a call from a hospital 2 hours away, and it certainly sounded on the end of the phone to him like it was giant cell arteritis, and he thought, should I get them to pulse this patient with remarkably high dose glucocorticoids, or just bring her to the hospital and have a look? And in the 2 or 2.5 hour journey, she went from being 6 on 9, so driving vision, to being completely blind in one eye. And maybe that would have happened anyway, but that's the thing about giant cell arteritis. I had a woman a couple of years ago who watched the Melbourne Demons win the grand final and then turned up bilaterally blind the next morning.
Gosh.
So really, really dreadful condition. So it's the referral that I'm never upset about seeing, because I would far and away prefer to be, doing temporal artery biopsies and proving people didn't have GCA than people sitting at home and wondering, could this or could this not be GCA? It's a really dreadful thing.
So, Rog, so they get a vasculitis. It's affecting the retinal artery.
Yeah.
And is that like if you were in primary practice? I haven't seen that actually. Headaches and facial pain. But it just sounds like it can advance very quickly. But is there a little indicator that the GP should be high dosing steroids and maybe calling the ophthalmological team as quickly as they can? What indicators that's where they should go?
Good question. So often transient symptoms precede these permanent sudden losses of vision. So that may be transient visual obscurations, amaurosis fugax, which is a blackening of vision, or even things like, there's a paper recently which found that transient diplopia and even diplopia in and of itself may be some early warning signs of giant cell arteritis. But certainly anyone with PMR that is on a steroid dose and then suddenly has an elevation in their inflammatory markers, ESR, CRP, and even a thrombocytosis, I would be concerned about developing sort of the cranial symptoms of temporal arteritis and needing to see, if not an ophthalmologist, a rheumatologist for a workup.
Right. Okay. Is that blindness that you described? Does that reverse with high dose steroids or
no? Yeah. So look, in that particular case, we gave the high dose steroids, but that's really to prevent the other manifestations, the cranial and cardiac manifestations. So yes, that's the terrible thing. Damage
was done.
Yeah.
Well, thanks for drawing that one to our attention. Tell us a little bit about Ozempic. Ozempic's being used widely now, of course, for diabetic management, but also it's really been hard to get hold of because everyone's using it for appetite suppression. Tell us a little bit about how that can influence the eyes. This is an interesting one for us to hear.
Yeah. So we can, thank TikTok and the Kardashians or something. I'm not super au fait with why this is such a problem, but I understand it's them and Elon Musk or something. So there's again, I think the audience will be well aware that the advantage of Ozempic, as well as the weight loss and appetite suppression, is that it achieves really good long-term, glycemic control.
Yes.
It tends to do that quite rapidly, and there's a well-described phenomenon in the ophthalmic endocrinology, classically in the context of insulin control in type 1 diabetics, where if we rapidly achieve normoglycemia from a high baseline HbA1c, we get this paradoxical worsening of diabetic retinopathy, which can proceed to irreversible loss of vision. And we're certainly seeing that with Ozempic, both anecdotally and as a secondary outcome from some of the studies done. I think they were the SUSTAIN trials, and there's currently a specific trial underway called the FOCUS trial looking at just this. And the secondary outcome they saw was that these patients tended to develop vitreous hemorrhage at a far greater rate, and hemorrhage in a diabetic cohort is indicative of progression to a proliferative form of the disease, which is the end stage disease and ultimately needs to be treated with laser, which in and of itself is a vision saving but also destructive procedure because it blasts away their peripheral vision to preserve their central vision. So I suppose what I'm thinking is, and I've had some relationships with the endocrinology team at the Austin Hospital, for example, where we worked collaboratively when they were desperate to get a patient's blood sugar under control and wanted to start Ozempic, but were prudent enough to say, look, I understand this patient's got terrible retinopathy. Is that the case? We said, yes, let's get some laser on board now to prevent the even worse scenario where they get these vitreous hemorrhage, which then causes some fibrosis and they detach their retinas and become irreversibly blind. So I think people maybe before putting some of them on Ozempic should either just clarify with the optometrist or ophthalmologist there's no significant diabetic retinopathy.
Yes. Right.
And then maybe just having an eye check either shortly before or shortly after, or both after starting the medication.
Yeah. Well, that's an important it's not a contraindication, it's important consideration, not an absolute contraindication. Well, thank you for bringing that to our attention. Can you talk a little bit about retinal vein occlusion? What should we know about there?
Yeah, so it's one of the causes of painless sudden loss of vision. It's something that we see a lot. It's almost invariably due to hypertension, and that's even the case in these less common scenarios where we see it in young people. And again, the GPs will know that hypertension is unfortunately of increasing prevalence. And I think the American Heart Association now says a normal blood pressure is 120/80 or something terrifying like that. And I say terrifying because I check my own blood pressure often enough to know that it's rarely that. So it's something that is probably caused by turbulent flow in an area where an artery crosses over a vein, and ultimately thrombosis occurs at that point. And there's no retrograde flow of blood through the venous system, and they get exsanguination of blood into the retina. It can be 20% of them are very severe and what we call ischemic central retinal vein occlusions, and the prospect for getting vision back in those is unfortunately very, very low. The treatment is almost always, and similar to giant cell uveitis, about protecting the other eye in those cases. So ameliorating the risk factors that led to that. And obviously, general practitioners have far more expertise and also often a far better relationship with patients to engage them in reducing those or improving those risks, better blood pressure control. And I often send my patients off for 24-hour blood pressure monitoring because you certainly do capture some episodes of hypertension that may not be evident when patients are in clinic. And, maybe part of that is also compliance related. We know from various studies that certainly in ophthalmology that if patients are due for their, glaucoma checkup, they'll take their drops for 3 days in a row. So they've got excellent pressure when the doctor sees them. And I wonder if perhaps that can be extended to blood pressure medication. Almost always to do with hypertension, and thus GPs are vitally important in helping prevent that problem.
Have you seen any COVID complications? Could that be one of the COVID complications?
Yeah, I haven't seen central retinal vein occlusions described. Certainly we saw a handful at the eye near of papilledema or bilateral disc edema from cerebral venositis thrombosis post both COVID and the AstraZeneca vaccine. COVID has caused optic neuritis, fairly well established. I think that it causes a type of optic neuritis, a post-infectious optic neuritis. I think it's conceivable or sort of, physiologically plausible, but I haven't seen it. Like I was saying, we often see these young women in particular get retinal vein occlusions, and they're thoroughly investigated for, protein C, protein S, factor V Leiden, and inevitably they will come back in my clinical experience and the experience of those far more senior than me, come back normal. And so it probably is still hypertension causing most of these cases. But yeah, maybe COVID has caused a couple of these, but I just haven't captured it personally.
The oral contraceptive pill not implicated in those cases?
Yeah. Look, I think increasingly the oral pill is being sort of liberated from these kind of insinuations that were previously abundant. So, for example, we used to think it caused drug-induced intracranial hypertension, and I think they've sort of said it probably doesn't anymore. I'm not au fait with all the other ones, but sort of the gestalt feeling is that it's not as horrible as perhaps we tried to make it sound at one point.
Thank you for telling us about that. My last question will be about the comments. Sometimes patients come in and they say to me, well, I've got macular. And I think they're talking about macular degeneration, but that's how they refer to it. Can you tell us a little bit about macular degeneration, how we might get some clues to it developing, and then what we should do?
It's a hard one to diagnose unless you're really good with your ophthalmoscopy, and I think this is again where the optometrists come in handy, and that's where our referral pathway comes from. Is optometrists. It's a relatively poorly understood condition, to be honest, given how prevalent it is. I mean, it's thought to be to do with the complement pathway, so some interruption in the complement pathway, and is some combination of degeneration and inflammation. Patients, it's often asymptomatic in the early stages, and in fact, the newer classification system has this sort of stage 0, which we just call aging-related changes, which just seems to be these yellow deposits at the macula that are really, really small, and it's thought to be this inability of the retina to sort of clean up after itself. And then at some point, a collection of that yellow stuff, which we call drusen, creates relative hypoxia and death of photoreceptors and the cells that support the photoreceptors, such that their valuable, high acuity cones are lost over time. And so eventually patients will, often the first thing they notice is they have trouble adapting from dark to light. So they may find it difficult to drive in bright light after they've been in an underground car park. They might find it hard navigating in a bright shopping centre after coming out from a cinema. Or they just may have trouble in general reading in sort of ambient or dim illumination. The type of macular degeneration that we used to fear, but is thankfully remarkably well treated at the moment, is the so-called wet macular degeneration, where eventually the itch or the hypoxia or the ischemia is enough to create new blood vessels that form from the choroid, which is a vascular layer sitting below the retina. But those blood vessels are sort of hastily built and tend to bleed or leak. That used to be a devastating end stage of macular degeneration, whereby the ophthalmologist would just say, I'm sorry, there's nothing we can do, you're going to go blind. And then the advent of those monoclonal antibodies or fragments of monoclonal antibodies, which we call anti-vascular endothelial growth factors, have revolutionised that treatment, although my understanding is may also be bankrupting Medicare. So it said glibly, but I think it's a real sort of thing to wrestle with, because I understand in New Zealand, for example, they use Avastin, which, as you know, is originally colorectal cancer, because it's so much cheaper. But of course, Avastin is no longer being made available in Australia. So that's a medical ethics discussion for another day.
Yes, we've got these amazing drugs, but we do forget there's a huge amount of expense involved in the application of them. But I guess saving lives and saving eyes is sometimes a very expensive undertaking. Rogan, I really appreciate the way you've taken us through that list of problems. It's it's very, very helpful to have that, and it's given us a massive insight. I'm just listening to you talk and thinking, you're very professorial, Rogan. I could see your career really pushing ahead. Tell me, where are you headed in it? Well, where are you going in your life? Where do you see yourself in the next 5-10 years?
Well, thank you for that. I like teaching. This isn't the classical type of teaching that I do, but I'm hopeful that I've managed to sort of shoehorn some of my skills into this 30 or so minutes. But I am fascinated by neuro-ophthalmology, and I'm hoping... So at the moment, I'm doing what's called a general ophthalmology fellowship, and I would be able to practice as an ophthalmologist next year, but I really want to do a bit of extra training and hoping to go to the UK to do a neuro-ophthalmology fellowship, and perhaps hence why I was talking about giant cell arteritis. It's certainly one of the cornerstones of neuro-ophthalmology. Part of it is I'm not particularly surgically minded, and I think I'm not fearful of surgery, but surgery still gives me both a rush of anxiety and excitement, but maybe not in the perfect balance that it does some of my colleagues. So, neuro-ophthalmology for me, practicing in Melbourne, I'd really like to go to regional Victoria to sort of pay back and reintroduce myself to some of those people that I worked with and met as an optometrist. So that's, I think, at least the next couple of years. And then, the wonderful thing about ophthalmology is that I'm really hoping I get to see all of my kids' main milestones, because people shouldn't be calling me at night.
Well, that's so important. It's very easy in medicine to get lost in the business of medicine and to forget about the business of being a father or a mother or, a parent. It's a mistake that I probably have made. So I take my hat off to you. And I think maybe your generation are a lot better at it than maybe I'm a standout as a bad dad. I don't know.
No, I think it's been made easier for us as well. But there's a bit of chicken and egg thing going on.
Well, look, thank you very much. I mean, the down to the Bass Coast, maybe, Rogan. It's a beautiful area.
Absolutely. Yeah, I love it.
I love that area too. Look, thank you so much for joining us. Really appreciate it. Good luck with your studies if you're going to London next year. And, really do appreciate your time with us.
Thanks, Lou.
Thanks so much. All the best.
Bye.
like to thank you for joining me in the conversation today, and I hope you've enjoyed it as much as I have. I think we've just been privileged to garner an insight into the complex universe of ophthalmology, and I really enjoyed Rogan's intelligent review of these common conditions and hope we can entice him back to tackle some other interesting eye diseases into the future. Well, during the podcast series, we will be covering a wide range of topics across many specialty interests. The discussions are not intended as specific medical advice for patients, but as general information only, and reflect the opinions of the guests interviewed. Requests for new topics to be reviewed and comments about the conversation you've listened to are welcomed, and may be emailed to manager@gihealth.com.au.